So you can then watch it, and then it will be on streaming on our website. And also, for those of you who want the Cpd certificate, I'm mainly speaking to the UK people because this counts for the Cpd. Please send an email to Kala, the person, the course manager who you've registered with, and she will immediately send you the Cpd certificate from all over the world. I mean, it's not necessarily for the UK. And David, we have a friend from Argentina, yes, Hugo Alera, who's watching us. So welcome, and thank you for joining us. I hope you have a fantastic Argentinian wine with you.
So let's start. I will start my presentation. So I think that last time maybe we finished with these slides. I think the webinar. So yeah, for those who do not attend the first webinar, it was a mistake. This is just a refresh, because as we told you, we believe in the aesthetic zone, particularly for demanding cases. If you want to be on the safe side, we believe the early implant placement is the best approach. With early implant placement, we mean a traumatic extraction, waiting 6 to 8 weeks before placing the implant. At this time, 6 weeks after the extraction, we know that we will have to build the bone with GBR, either using on the left side cross-linked collagen membrane if you only have an horizontal bony defect, or using a titanium reinforced membrane if you have a vertical defect. Of course, when you have an important vertical defect, you have to postpone the implant placement. If you have a 3D defect with an horizontal component and a slight vertical component, then you can place the implant together with the GBR.
Yes, and guys, just a little input. This is a decision tree that is based on the scientific literature. So it's not just like, it's not our opinion. I want to make this very clear, because we are easy, relaxed, we're having a glass of wine. But when it comes to, you know, focusing on how we're treating patients, this is a decision tree based on the evidence that we have in the literature, plus the many years of clinical experience. I think that has to be said as well, because after having attempted a lot of different probably techniques and maybe having had failures, right, David, we really came to a conclusion in terms of how we approach our patients. So it is really two macro things, the evidence-based and our clinical experience. And I think this has to be said.
Yes, of course. Many failures before being able to put this
together.
So as soon as you place the implant together with the guided bone regeneration, then you have to wait for the healing, in most of the situation between 4 to 6 months, and then you can manage the soft tissue. And we want to describe tonight how we believe it's nice to manage the soft tissue. So as you can see, 4 to 6 months after the implant placement and the GBR, you can manage the soft tissue. And we want to share with you 3 different techniques that we believe are very useful. The first one is the roll flap technique. It's a very simple technique, but you need to have almost no soft tissue defect and a good biotype. If there is a slight horizontal soft tissue defect, then you can use a connective tissue graft at the time of the healing abutment placement or at the time of the provisional restoration placement. If after the GBR you still have a vertical and a soft tissue on a soft tissue and an horizontal, sorry, soft tissue deficiency, then you have to place the connective tissue graft first and postpone the uncovering.
Yeah, so I like how we created this flow chart, because guys, let's make it very clear. When we want to achieve optimal, not only aesthetics, but long-term stability of the tissues when we treat our patients, take in mind this message that we have a 50%, which is thanks to the hard tissue reconstruction, so everything that is bone and which is in the upper part of the slide, and 50%, It's the soft tissue, and this has been clearly demonstrated in a relatively recent paper by the Swiss group. So we have two major components, the hard and the soft tissue. So now we're going to concentrate on the soft tissue, which sometimes is more tricky than the hard tissue, isn't it, David? I mean, managing the connective tissue in the right way, sometimes you take too much, sometimes you take too little. And I think that we should show them even the suturing and how much and from where we should take the connective tissue, because that also makes a difference. So let's focus really only on this bottom part of the chart, which has the aim to give the beautiful aesthetic appearance and the long-term stability.
Also, one important point is when you place a non-resorbable PTFE membrane, of course, you have to remove the membrane, whether you have placed the implant at the same time or not. When you remove the membrane, if the implant was placed at the same time, then at the same time of the removal, you have to place the connective tissue graft, and postpone the second step surgery. So let's go through the techniques, because it's easier at this time of the day. So the harvesting technique, just two video. We have two locations, as you know, the lateral palate with the trapdoor technique, and this is one of our favorite place to harvest connective tissue graft. Of course, when you use the trapdoor, the limitation is the first molar. You have to be very careful. You can draw a line between the first and the second molar. You can draw a line, and here in this area you have to be very careful. So all the time, it's I think better to be at the level of the first molar to perform.
Yeah. I would say that one of the tricks of this technique is to make sure that the connective tissue is harvested basically at the same thickness, right, David? So we don't want to have a thin part and a thick part. And also, essentially, we would like to have. Yeah. What were you saying?
Here it's in fact we just perform a flap, and we have to be very careful to keep a flight of sufficient thickness in order to avoid the necrosis. Of course, in this area of the palate, we may have some glandular tissue, and the quality is not always perfect. And if the thickness here of the flap is sufficient, then there is no problem to go deep in this harvesting and to reach the bone, and to also harvest the periosteum. If it's very thin here, then you have to be careful and don't harvest till the bone. In this,
because otherwise you denude the area, because the superficial flap is so thin that it will go in necrosis, and the patient will hear by secondary intention, and it is very, very painful and certainly not appreciated by our patients.
But you see, in this case, it's a thick connective tissue graft, and it's touching the bone, so we remove the periosteum. But as soon as the thickness of the flap here is sufficient, there is no risk. And I mean, this is one of the techniques we use on a daily basis. So, and the post-operative discomfort is not important, because as you can see at the end of the surgery, it's just one line.
Yeah, and we don't put any plate or any protection or anything. I mean, now it's really unnecessary, because of the technique it ends up having a very nice post-op healing.
The only thing is that if the flap is very thin here when you do the harvesting, then don't go till the bone, because then the risk of necrosis is important. So you can
sometimes, you know what I do, David? Sometimes I put a little collagen sponge underneath to be able to, because when you harvest quite a thick layer of connective tissue, then the overlying flap tends to collapse inside. So sometimes I just position a little, collagen sponge, which is really cost effective, and it gives you the same thickness as it was before, so that you can suture it easier, and the patient doesn't feel the concavity.
Yes, and also sometimes it's helped with the bleeding. There is another technique that I don't really like, that has been described by an Italian group, which is harvesting in this area, particularly in this area, an epithelial connective tissue graft, and to remove the epithelium. Why in this area? Because the quality of the tissue in this area is much better. So this technique should be used in this area, but then you are always limited by this. anatomical.
Yeah, no, I must say I defend the Italian group only, and here comes David and I fighting as usual. No, I defend the Italian group, but David, that is normally done for root coverage procedures, which really require a small amount.
Yes.
I mean, we're not talking about here, we're talking about second stage surgery, peri-implant, soft tissue management, which is completely different because that we need the volume, otherwise we wouldn't be doing it. However, in root coverage procedures, the quantity and even the thickness is way less. So that's why I think that technique is a viable technique for that. It's an indication.
It's a nice technique, but it's about indication. Of course, if you want something thick, it's not possible on the posterior palate. And if you need something not that important in size, then you have another opportunity. It's the tuberosity, which we really like, because in terms of post-operative discomfort, I think it's really less than harvesting an epithelial connective tissue graft. So
which at the end of the day, the surgical technique of harvesting this tissue in the tuberosity is like the distal wedge technique. Do you remember when we started perio training and the typical pockets at the distal side of the 7? We used to do the distal wedge technique, and at the end of the day, it's the same, right?
It's really the same technique. In most of the case, you can harvest quite a lot of tissue from the tuberosity, of course, and it's really no post-operative discomfort for the patient at all. Of course, sometimes the access is not that easy, and it's a reduced amount. It's very thick, so sometimes you can really slice the graft in order to have like 2 or 3 grafts. But I think it can replace sometimes the harvesting in this area, because in this area you are also limited in terms of size.
I have a question for you. What do you do if you have, obviously you do this if you don't have an 8 present, but what about if you have an impacted 8?
I mean, if it's very, very deep, then it's not an issue. If it's not that deep, then I think it's you have to avoid this area.
And how do you check? Because it's in a logical manner, you obviously want to do it if the 8 is covered by alveolar bone. So you basically, it's almost as if it wasn't there. And do you justify a CT scan to check this? Or do you check with a PA hoping to understand where it is?
Yeah, PA would be better, because I think it's CBCT just to check the position. Might be a little bit too much.
Yeah, it's too much. Okay. So at least
so I think that, I mean, with the lateral palate and the tuberosity, it's not the same quality of tissue. And let's say that if you want something very, very thick, the lateral palate is much better. And when I say the lateral palate, in the anterior part, because in the posterior part of the lateral palate, it's more or less the same as the tuberosity for me. Very good quality, but less amount. And of course, in this case, you have to play with the tuberosity. You have to remove the epithelium, and then if you need something longer, then you can play with this tissue to increase the length. It's really depending on what you need. Do you need something thick or not? Do you want to cover 2 sides? And then you can decide the shape and where you have to harvest the connective tissue. So we have
David, sorry, I interrupt you. I think it's very important also for who's listening to remind ourselves that this connective tissue from the tuberosity is way more dense than the one in the palate, which means that the vascularity is more difficult for Mother Nature to enter, which means that this tissue necessarily has to be completely submerged under the flap. So there's no such thing as leaving this piece of connective tissue exposed, because if that happens, there's a very high chance that it goes into necrosis. And I think this is very important.
Yeah. Even if in most of the time, I think it's better to submerge the connective tissue graft to improve the healing.
No. I mean, in theory, I mean, every connective tissue should be covered. If the palatal one remains exposed, it's not good, but it's probably not the end of the world in that sense. But this one really gets into necrosis easily. So
just go through a case so that we can discuss the soft tissue. So it's a case of early implant placement. So we'll go a little fast to focus on the soft tissue. So this tooth is of course upless, an important resorption. There is already, you see, a soft tissue rotation and some kind of inflammation. As you can see, there is some remnant of the endo treatment, and obviously not possible to keep the tooth. There is a lack of cortical bone. So in that case, we prepare the provisional restoration prior to the atraumatic extraction. And this is the situation 6 weeks after tooth extraction. So placement of the implant in the correct position. We can take an index just to register the position of the implant. It will allow to prepare a provisional restoration in the lab during the healing time. Of course, GBR, we will use in this case a crossing collagen membrane. That's why we always over contour when we are using a collagen membrane, and then we close and we wait. Here we wait 4 months, and then starts the soft tissue thinking. So I know that I have the implant in place. The ortho integration process has already started, and even more, of course. And we have the GBR. So now we have to be minimally invasive, because here in this area we have the GBR. And after 4 months, the less we touch this area, the less we touch this new bone, the better it is. So we have to evaluate the soft tissue. Of course, if you have this very easy impression, you can do it digital as well. Then it allows to prepare in the lab to save time, the time in the office, to prepare the provisional restoration. So here, as you can see, the biotype is very favorable. So you don't have to do much. You just have to do a small incision in this area, remove the epithelium using a scalpel or using a burr, and you can push all the tissue in the buccal area to improve a little bit here the convexity. And at this time, you can either place the healing abutment or place the provisional restoration. In that case, we have the provisional restoration that was prepared in the lab. So you save time and you have the perfect shape. And this is the case down the road. And you can see here the maturation of the tissue with time. And if you want to be successful down the road, the management of the soft tissue and the improvement of the soft tissue, even with this type of surgery, is important. But in that case, the biotype was good first, and we had almost no soft tissue deficiency. And sometimes you have this soft tissue deficiency. So just a small note.
Let's see the technique. Let's see the technique.
With just 3 incision, and then this part you have to remove it. So you have to remove
the epithelium. You have to remove the epithelium, not remove the flap.
No, just remove the epithelium using it. Here it was a scalpel. Today I just use a burr, and as soon as you see the bleeding, you know that you have removed the epithelium. And then you can push the tissue, remove the cover screw, and then this part will be pushed under this flap. So here, what you have to do is to prepare an envelope, partial thickness. You have to try to avoid touching the bone, because as you remember, in most of the situation, you have a GBR in this area. So you have to prepare an envelope, partial thickness, in order to push this tissue in this area without too much tension. And then you can either place the healing abutment or the provisional restoration. And you can see, as soon as you push the tissue, you improve a little bit the soft tissue outcome. So it's not an important surgery. It's really minimally invasive. Most of the time, you don't need suture, but you will slightly improve the soft tissue contour. This is a very good technique if you have a good biotype and no soft tissue deficiency.
Can I stop you? Go back. Go back. Go back. Go back.
Go back.
Because the incision of the row flap is obviously the same width of can you hear me, the healing abutment, the cover screw, then the only thing that I'm worried is those little mini scars, or the fact that the row flap.
Can't hear you very well.
Okay, wait a second. Well, anyway, you can go on. My query was about scarring.
No, and you know, even if you have scar, you will have scar here in this area, and it's impossible. There is no visibility because it's really occlusal. So you will. I mean, no, it's really not an issue.
Okay, let's go on.
So this is the outcome, and down the road, you see it really creates this convexity that will improve the long-term success. And if there is anything happening in the GBR down the road, because we know that bone remodeling may occur, then this excess of soft tissue will prevent the soft tissue shrinkage. Another case, I'll go quickly. The tooth is hopeless, extraction, atraumatic extraction, wait 6 weeks, place the implant, defect to be treated with GBR. We close, we wait, and then we evaluate. And here in that case, the GBR was correctly performed, but still 4 months down the road, we have a soft tissue defect. So here, the roll flap technique is not sufficient because as you can see, if you look, sorry, maybe, I know I don't have the buccal view on this case, but when you look at the case from a buccal orientation, it looks like very good, but you always have to look at the case from an occlusal perspective, and then you can see that there is this discrepancy between this area and this area. So here, the raw flap.
Which, by the way, it's very common to see. So don't freak out if your case is after, because if you look at the GBR that David has done in the previous slide with the surgery, he over contoured. Even though, look at that, you would never expect to have, if you think about it, a buccal issue after all of this graft that has been positioned. However, let's remind ourselves of the biological processes that occur, because when you then suture, of course, the muscles and the muscular pool is strong, even though, and that's why we always over contour when we're using resorbable membranes, right, David? I mean, it's very important to understand the logic of what we're doing, because it changes dramatically.
This is also the issue with resorbable membrane as compared to non-resorbable membrane.
Yeah, because basically they're squashed. They're squashed by the muscles, even if you over contour.
But that's why with non-resorbable membrane, you don't have to over contour, whereas with resorbable, you have to over contour, and still you may end up with this situation. You may end up with this situation also with titanium reinforced membrane, because you have a thinning of the soft tissue when you use the EPTFE membrane. But it's not a big deal, because at this stage, you can do a small incision over the cover screw, slightly on the palatal part. Then you can push the tissue, remove the cover screw, and again, you create an envelope in this area. The envelope should be a little bit bigger than with the roll flap technique in order to allow the placement of a connective tissue graft in this area. And you have to be careful, because you have to look at your case and to see where you need the connective tissue graft. Because in some of the case, you need also to have a longer connective tissue graft also in this area to improve the final outcome. So the size and the shape of the connective tissue graft will be really related to the soft tissue and the soft tissue defect you have evaluated. And then with time, you see the improvement of the soft tissue, and now you know that you are on the safe side. And even if something happened on the GBR down the road, you will be on the safe side on the long run. So this is the outcome and the stability of the time of the soft tissue and the bone. Yeah.
So it's very important to underline. And by the way, guys, if you have any questions, I mean, this is the chat. This is not a webinar. This is it's a webinar, of course, but it's a way of sharing our everyday cases. Okay, so David, did you want to talk us through this technique, which is exactly what you have shown us?
Just a small illustration. At the time of uncovering, there is a small soft tissue defect in the horizontal component. So
do you get the papillas? Do you, because it's very important, because I know that you shouldn't touch the papillas, right? So you only are over the cover screw.
It should be really minimally invasive over the cover screw, and then you try to create the envelope. This is a very small surgical scalpel. It's allowed really to be partial thickness and to preserve the GBR. So it's really, it should really be minimally invasive to get enough flexibility.
And guys, you cannot do this with a normal 15C blade. You have to use these extremely thin instruments because it's impossible to, can you see how basically you have to create a pouch without cutting in a one single tooth site.
And also this, you can also bend this scalpel, so it's easier. And then look at the instrument. You can see the instrument. It's very superficial because you have to create the envelope in order to place the connective tissue graft without touching the bone. So it's a nice surgery, but it's not that easy. And then you can harvest the connective tissue graft. Should not be that big in that case because it's a small area, but it's a graft from the tuberosity, so it's pretty easy to suture, and the quality is good. But then, as Isabella told you, you have to really to place the connective tissue graft within the envelope. It is very important.
And not only within the envelope, as David said, make sure that you actually position it on the buccal portion, like abundant on the whole buccal surface. So you don't want to just make a mistake of actually only being too narrow, too small. You want to really give that nice round appearance of your contour once everything is finished. I like this suturing technique. If you want to spend a few seconds talking about this, because I think this is a very practical tip, which I have learned from you, and I think it's really cool.
Up.
There. No, I think you go back a little bit. So basically, guys, the aim is to actually position the connective tissue, mesial and distal, in the perfect position. And you achieve this by doing what David is going to say.
Sometimes the people, they just want to do one suture to save time. And then they go in, out, and they take the graft only from here, from the mesial to the distal, and they get out. But it's not sufficient because then the graft turns and you cannot control the position. Whereas if you use a mattress, two vertical mattress suture, you can really control the position, and I think it's really the best option. The only thing is that here we enter in the envelope in the apical part, then you go out, and then you have to enter the graft from apical to coronal. If you enter from coronal to apical, then it will twist. Okay, so you enter apical, you get out, and then you can enter in the graft apical and get out coronal. So you see, it's a mattress.
Yes, it's easy to remember, apical and apical.
Yes, and then from coronal, and then you get out coronal, and you do the same on the distal aspect, and this way you can control the position of the graft. And again, the same. Okay, just the last situation. Look at this case. We were talking about CBCT, Isa, and we used to say in the course that the most important X-ray in the aesthetic zone prior to implant placement is a classical X-ray. In that case, there is a root fracture on the tooth 12, but here it's very important to notice the bone level, because if you lose, like in that case, the adjacent bony peak, then you know that something may happen. What? The soft tissue, the loss of the papilla. So it's very important when you look at this case, you have to tell the patient, look, here there is a bone loss, so we may have an issue with the papilla, particularly because here there is a crown. So when you have a crown and you elevate a flap, you know that something may happen, particularly when the bone is missing. So again, atraumatic tooth extraction and temporization, wait 6 weeks, implant placement with GBR. As you can see, there is a bony defect. And here we can see that there is a vertical bony defect. This is not possible to correct. So having a vertical bony defect and already a crown, we know that it's an issue. So we try to improve the outcome with the GBR, but as you can see, 4 months down the road, it's not perfect. So here we have a soft tissue deficiency in this horizontal dimension, but also vertically. If you want to correct something vertically within the soft tissue, it's not sufficient to place the connective tissue graft here. You have also to place the connective tissue graft over the cover screw, which means that you have to postpone the healing abutment placement. So this is what we perform here. We use much thicker and larger connective tissue graft harvested. I don't remember if it was from the palate or the tuberosity. You have to secure the connective tissue graft first on the palatal area and then on the buccal area. So here you are able to correct the soft tissue deficiency in the vertical dimension, but also in the horizontal dimension.
Now, David, in this case, you perform. It's important to say the crestal incision goes from papilla to papilla because you have to have access. There it is.
Right.
And it's important to show exactly the technique. Unless you have a video of this. Do you have a video?
Yes, I think I have.
Okay. But anyway, the crestal incision is from papilla to papilla, and the creation of the buccal flap remains the same as before, with the difference that you create, that the initial incision is different, right?
Yes. Here, we will see in the video, but you're right, it's important that here we elevate the papilla, but still we try on the buccal aspect to be partial thickness, because again, we know that we have a GBR.
Now, Orestes was asking whether in this case you would have opted for an ortho extrusion.
Could be, but the issue is that if you look at the X-ray from the beginning,
I think there was a fracture.
Here it's a fracture, but you can try, but then building the bone, what is missing is the bone in this vertical component. And I'm not sure you will be able, I mean, it's a long treatment, and then you have to secure the position for a while. And I'm not sure about the benefit. We have been talking about the orthodontic extraction for a while, and at least the benefit in the vertical component of the bone around an adjacent tooth is not 100% sure. So I'm always concerned by using a technique that will take time and where you have no security in terms of the outcome, but it could be an option.
Yeah, we have two friends who are asking also the details about our microsurgical blades. So if we wanna tell them, they want to know the brand and where they could find
the company. It's a company in the south of France. It's called MGK, and they have a very good material. I don't know if you can see my screen.
Well, we can see, yes. MJK. MJK is the company, and it's a bendable and straight microsurgical blades, because those are blades. I take them from another brand, but basically they're the same. And
these are French, huh?
Yeah, so they're better, right?
Not the same. But you can find.
Who asks is, by the way, from Toulouse. So voila. So MJK, there you go. You've got the answer.
Marseille, and they're very kind, and they have very nice tool to make our life easier. So
it's incredible, and also the bend. Sorry if I insist, but the bendable ones, I have found they have changed my way of working. I mean, you can achieve the partial thickness pouches, even in mucogingival surgery, root coverage surgery, like never before. I mean, I really now use them almost as frequent as the 15C, even in normal surgery, because they're phenomenal. They say they come from the ophthalmic surgery.
No, it's very nice, and it's also speed up the surgery because more accurate. Yeah. So just an illustration where there is a soft tissue deficiency in the vertical and in the horizontal dimension. So
my God, how I miss working, David. This lockdown.
Yeah, but I think that the first month will be a pain in the, because I mean, the situation is not back to normal, so it will be still quite difficult having like 2 patients.
But you see, guys, this crestal incision is full thickness initially, because you have to access the right? Oh no, actually, no, because this you're closing.
I prefer to do it full thickness because I like at this stage to unscrew the cover screw and to rescrew it. Why? Because I know that I will do the uncovering 1 month later, and I want to do the uncovering. You see, I just unscrew, check, and rescrew it. Just because I know that at the time of uncovering, I want to do a 15-minute surgery and be sure that it's not too tight and very easy to access. Because sometimes you have some bone and it's very difficult with very small incision. So at that time, the access is very easy. So I think it's nice to unscrew, to remove. Sometimes you have some bone, so you remove the bone and you know that after 1 month of healing, you can remove very easily. So in that case, it was really, I had a defect. I should have put the buccal picture because there were a vertical defect only in this area. If you have a vertical defect involving also the papilla, then you have to use a larger connective tissue graft.
Like we were saying.
So you have to adapt. I mean, it should always be as minimally invasive as possible. So the incision should be where you need it. And also you have to place the graft where you need to place the graft. But here, as I need to improve the thickness in this area, of course, it's not possible to place the healing abutment at the same time. So you place the graft, you wait 1 month, and then you have a very, very short surgery.
Yeah, and if you see the suturing technique is very similar to the previous one. It's a vertical mattress that captures the connective tissue and holds it perfectly in place, which is very important to be able to position it exactly where you want. Exactly. And I do finish with this is Prolene 70, I guess, yes. And it's a fantastic suture too, especially for the papilla area.
Even if you have to be very careful with the tension of this suture because it may tear the tissue. So if you have inflammation, I mean, it's as compared to some other like PGA sutures, it's a little bit more. It's a little bit more demanding, and you have to be careful with when you suture to avoid tearing the tissue. Maybe you want to share your screen, Isa? Talk about bone back.
Yeah, I mean, guys, I mean, was it clear enough in terms of I think the second stage surgery, which is what we have just discussed now, sometimes it's really much overlooked. People are concentrating on the bone level, and then they like, second stage surgery is just, finding the cover screw, pushing the tissue, and putting either the provisional or the healing abutment. And I think this is a big mistake because it's at this stage where the soft tissue conditioning begins. And I very much like, David, do you want to spare a few words on, I'm a fan of your index taking when you're actually positioning the implant in the first place, because I think it's a very simple method, which, for example, I remember Orestes when we treated Nina. By the way, in the previous aperitivo we had 10 days ago, I showed Nina's case. And do you remember, Orestes, when we did Nina together and you did the pros behind, you did the provisional, and I said, it's a shame we couldn't position the provisional immediately when we did the second stage plus the connective tissue graft, because I think it's something very smart. So tell us exactly how to do this.
Today we do it digitally. It's much easy. If you have a surgical guide, it was the case here. You just have to place. So the implant is there. Huh?
Yeah, of course.
So you do as you take. It's like a regular impression, but it's just a position. You just have to position, and then you can remove it. You have to be careful because if there is not an important implant primary stability, you have to be careful. That's why today we go for digital. The aim is just to register the position of the implant to allow the lab for the provision. Your phone ringing, Isa? So I go back. In the lab, they can there is some noise. I don't know if it's my phone. In the lab, they can replace this impression.
I can hear you very well.
Because I hear a phone, so I don't know if it's yours or mine.
No. No, it's not mine.
And because some of the people, they do the provisional restoration chair side.
Yeah.
Take a long time, and you cannot, I mean, at least with my end, I cannot reach this level of quality. So I think that this, you take just an impression of the position, either with these tools or with digitally, and then it's allow you to prepare during the healing time the provisional restoration. So it's really easy, but I think that digitally it's much easier, because here the issue is really to lose the primary stability of the implant when you remove the impression. So it's just, it's just an impression cupping, and you just secure the position of the impression cupping using wax, or it's even easier if you have a surgical guide. And then, in the cast stone, they remove the cast, and they just replace it so that they have the position of the implant. And then as soon as they have the position of the implant, then they can prepare the provisional restoration.
Yeah, no, I find it really smart, because compared to, for example, for us, David and myself, I mean, at least I speak for myself that I'm not a prosthodontist. It's really smart, because instead of just positioning a healing abutment, which flattens then the tissues, you already start from time zero to condition with the right contours. And then of course you can manage the contours of the provisional restoration. But this really gives a nice support, especially for the papillas.
And also, what is nice, as Isabella told you, if you place the healing abutment, then you start the healing with the shape of the healing abutment. Here, you start the healing of the soft tissue with the correct design. And also, if the lab is very trained, most of the time you don't have to touch the provisional restoration. If the lab is less trained with this technique, you just have to look at the position of the gingival margin, and then you just remove to make it concave, and then you have the place for the soft tissue. Of course, you have some bleaching when you place the provisional restoration. You have to be careful. It should disappear roughly about 5 to 10 minutes, because if there is too much pressure, you may have some necrosis. It's already happened to me. This is not fun, because then you may lose some of the tissue you have put so many effort to build. So you have to be very careful. You need pressure, you need bleaching, but not too much. And yeah, roughly after 10 minutes, it should disappear. And then the patient can go back home, and you have to see the patient back like 2 weeks down the road in order to check the position, and then to change, if required, the shape of the crown.
Yeah. No, I think, guys, do you have any questions on the soft tissue, let's say second stage or initial phase of soft tissue contouring? So we've really given you the 3 scenarios, which I think are crucially important, because it's something that we do on an everyday basis. So if you don't have any more questions on this, or maybe you have them later, it's absolutely fine. David, shall we go on and looking at a bit at the bone?
So now you can share your screen.
Okay, so I'm going to share my screen, and let me see. So from where I finished last time. Okay, tell me if you see Paul.
We see his name at least. Okay,
that's already a start. And let me see. Okay, so I'll show you a video of Paul. Paul he's a lovely guy, and one of my best patients from a character point of view. That he's amazing, and we actually treated David during one of our courses together. And I will show you this video. Oops, I'm gonna. Sorry. Can you hear the music as well?
A good aperitivo is with music, huh? By the way.
Yeah, I mean, so let me just go through the video with the music, because I can't speak over the music.
No,
I didn't know we had music. And then we can comment on it, because I also have the clinical pictures. There, look at the bleeding.
Maybe remove.
This is way too big. So you do like my cheesy music, eh?
Yes.
Okay. Now, guys, I mean, I couldn't speak over the music. So, basically, let's start from scratch. So, for example, if you looked at the video, one thing that I have completely changed is the harvesting of the autogenous bone. I don't use those big safe scrapers anymore, but I use the micro scrapers, which are the small ones, because that one was massive and huge. And I think you could notice the bleeding. David, could you see the bleeding from the incisor canal? That is, typical when you have a large incisor canal, and when you have this area to treat, you must be extremely careful not to detach the bundle, the vascular bundle, which in my case, even though I think I was careful enough, obviously I wasn't that careful, because it broke and it started bleeding a lot. And my surgical assistant, Saffron, who Orestes knows very well, collapsed on the floor. So it was kind of an exercise during a course, live surgery. But anyway, having said this, this is Paul. You can see the defect, and this is the CBCT scan reconstruction. You can see that the defect is in the aesthetic area. Here you can see the large incisor canal, and it is the vertical component. So we have gone through the decision tree last time, but definitely a case where you would differ. You would not position the implants at the same time. You want to recreate with a three-dimensional scaffold the actual bone. You can see the before and after. This requires 9 months of healing to be on the safe side. And you can see that we have nicely recreated what we actually like. We want to recreate the bone contour as natural as possible, almost as if you wanted to go back in time. So rebuild the bone that was missing. This is the appearance when we reopen after 9 months. And it's lovely to see that this membrane, which is a PTFE non-resorbable membrane, it's not a titanium mesh. It looks a mesh when you open it up, simply because it is basically a titanium shield interpositioned in the middle by 2 layers of PTFE. And these layers are very well adapted to the soft and the hard tissue. And when you peel it off, normally everything comes in one go. And this is the appearance of the regenerated volume that we have. Now, you can clearly see that positioning implants in here, it's obviously more favorable than in the case as we started, because now we have a thick, wide, physiological ridge of a compost. It's not 100% bone. It's a vascularized compost of approximately 40% of newly regenerated bone and 60% of scaffold. So we know what we have positioned there as a scaffold. I mean, I'm going fast because I think you all know, the basics of this, but if you want, I can answer then every detailed questions. But what we use is a 50% autogenous bone and 50% xenograft. David, tell me.
One of the questions was, do you cover the EPTFE membrane with a native collagen membrane?
Yes, I tend to cover it with a native collagen membrane. Probably here I didn't. When I have a slightly exposed graft, which normally happens mesial or distal to the existing teeth. So because the PTFE membrane cannot touch the adjacent teeth, we tend to stay approximately 1.5 millimeters or 2 millimeters away from the teeth. Sometimes the nature doesn't give me a nice balcony of alveolar bone where I can simply attach my membrane, but I have to recreate this balcony. And by doing this, I put the graft, which then requires coverage by a collagen native barrier membrane, which can kindly and easily attached to the adjacent teeth.
Isabella, can you give us some details about how you fix the membrane, particularly on the palatal area, and where do you find the EPTFE membrane? And then I will have I will reply to a question on PRF because it's a French product.
Okay, so the membranes, there are mainly two big players in the market for membranes, and we don't have any conflict of interest, so I can easily share names and commercial names because we are having an informal aperitivo and we have no conflict of interest. The two names are the Osteogenics has the membrane called Cytoplast, which is dense PTFE, and it comes in two different thicknesses, the thinner and the thicker one, and it is a very valuable membrane which I have been using a lot. Whereas this one that you actually saw in this video is the Neogene membrane from the company of the implants called Neos. So they make this membrane which has a 3-layer membrane, as I said, a PTFE layer, so slightly expanded instead of being fully dense, and then in the middle the layer of titanium mesh, the ones with the holes. I find this membrane extremely easy to use because it's a very easy flexible membrane. However, it holds the graft in place. How do I secure it? You have seen from the video that in the palate I use some Profix screws, which are fantastic because they are self-tapping and you use a handpiece, which means that because if you have to use the mallet and the straight long pin holder, you can definitely use it. So I use both to make it clear, but in the areas where, mainly in the lingual or the palatal area, where it's very hard to use a very long pin holder, the angulated handpiece with the screw helps you enormously. You've seen it from the video. It's very simple to use, and then I'll show you another case with the video which hopefully will show you the difference between the screw and the tack, because normally on the buckle I use the tacks.
And one other option is the suturing technique on the palatal area, which
I hate. I don't know, for some reason I just hate suturing because it doesn't give me the solidity that but I really like the membrane to be completely hard and super duper stiff, and that is the key to success. Now, David tends to suture it on the palate, which gives stiffness as well, but I believe that the tacking or the screwing gives really a box, and you don't touch the box. I don't know why you don't like to screw them on the back, but
just another opportunity, because sometimes you may have some issues, and
yeah.
it's nice to have this in your
No, I must admit, do you remember, David, when we did the course, we were in Paris, I think it was 3 courses ago, and your case in the palate, I must admit, the palate was awful because you didn't have any flat surface. Now, one thing that has to be said, guys, is you will see, you've seen it from the video, you'll see it from the next video, the screws or the tacks, whatever you use, have to go in hopefully perpendicular to the base of the bone. And sometimes this is impossible because the palate is not a piece of plastic. Sometimes it has defects, it's got, the wobbly architect, and you just don't find the area. And that's the reason why David has correctly sutured his membrane to the palatal flap, right?
Yes, exactly. So just question about the native collagen membrane to cover the EPTFE. It can be, it's native collagen membrane, so you can use
I normally use the BioGuide.
Yes, we use BioGuide, but there is, I think, several brands.
Yes. I use BioGuide because, of course, the extensive research behind the BioGuide. We also have to make sure of what we use, because I don't like giving out any collagen membrane. I think we should really be careful in what we use with our patients, and it has to be a very serious and thorough, researched biomaterial. For example, even the xenograft that we use is the BIOS, because it gives you, we've been using this for ages, and we've done a lot of histology with this.
This is a very, very good point, because this is also because there is one question on the PRF, and this is the reason why we do not use the PRF. The EAO has just launched a consensus conference on the use of PRF, and there is really, really weak data on the impact of PRF on the soft tissue. And once again, there is no miracle. With this technique, if you don't manage correctly the soft tissue, you will end up with an exposition and a difficult complication. So PRF will not save you. And if you manage correctly the soft tissue, in fact, you don't need the PRF. There is also one question about the mucograft to replace the connective tissue graft. And I think that Isabella and myself, we have both the same experience with this product. I think that if you don't need a connective tissue graft, then you can use the mucograft. If you really need a connective tissue graft, so far we have to use the connective tissue graft. And of course,
it does not replace the connective tissue graft.
Yes.
If that's the question, right? It doesn't replace it. I mean, we wish and we hope, and trust me, I'm the first one in line. Even with the fiber guide, the new material that Geishlik has given us, which is better than the mucograft. I mean, it's a fantastic idea to replace the connective tissue graft. At the moment, the studies do not give us any data that could completely replace it. I must admit, we're still studying about it, so never say never. So it could well be, and trust me, David and I will be the first one enthusiastic of eliminating connective tissue, because of course, for the patient, it's a pain. I mean, and it's much easier because, I mean, imagine having a quantity available, because what we struggle normally is the quantity of autogenous connective tissue graft.
We have a very, very good question from Toulouse.
Oh.
Because it's a question about complication, and we are all facing complication. I mean, not complication, but difficulty.
Yes.
About the quality of the bone, and the fact that sometimes down the road, even after 9 months, it's still baby bone, very soft.
Yeah.
And sometimes it's not that easy to reach a correct implant primary stability.
No, not at all. Now, if you see this picture, if you see this picture, you see a beautiful vascularized volume, right? So if you look at this picture and you didn't know, you're like, wow, now I'm going to put these 2 implants and I'm going to put them in marble. It is absolutely not like this. This is baby bone, and even if it's 9 months, which sounds a lot, it's nothing for big vertical defects, because you must understand the potential. I am fascinated because GBR, if you think about it, is a really fascinating process that the body repairs and regenerates where there was no bone. So we need to respect this. This means that it is extremely soft. I would even call it a quality 4 bone, or sometimes even less. And when you do the implant preparations, when you position your implants, I believe this is the hardest bit of the surgery, because you never have to under contour too much. Paradoxically, people think that if you under contour, your implants will go in with a stability, with a greater stability. But it's the opposite, because if the implant goes in too much of a harsh way, then it will break this compound. So I always give the tip to prepare the site slightly under contoured, sometimes even at the same diameter of the implant, because the implant then gets the primary stability from the native bone, which is way harder.
Isa, we have a video, I think. Maybe I share it?
Yeah. And then I go back. So
come back. So just because to see that it's happened also to us. You unshare and I share just about to.
Yeah, I don't know why this thing is not working about the sharing. Okay, I'm with you.
Boom. Just.
I'm reading it from Leline Paten. By the way, the baby bone is my terminology. It's not Eastman's. I'm just joking.
I just yeah. Everybody, you know, you should register the name, Isa.
No. I'm happy to give credit to others.
Yeah, you're right. So this is just to share a case where, as you can see, it's not possible to place an implant. So it's the same technique as Isabella just described. It's a mixture of autogenous bone and...
This is a cytoplast membrane, guys. You see the difference in aesthetics.
And it's, oops, palatal.
Sutured.
Sorry.
It's sutured. No, it's nice for them to see the difference.
It's another option. Just this is the management of the soft tissue. So you know, just to show you down the road, 6 months after the surgery, the bone we get, and it was not that easy to place the implant because the bone is very soft. So this is the first surgery, and then the re-entry surgery at 6 months. This is the tissue. I'll go a little bit faster. So this is when we remove the membrane. And then the drilling.
Yeah.
And you will see in this area, when we place the implant, whoa. So you have to be very careful. But once again, in implant dentistry, we always believe the more implant primary stability, the better it is. This is not true. It's true when you look for immediate restoration. Then you need sufficient implant primary stability. But don't forget, this is a living bone, and the best osseointegration will be when you have 10 or 15 newtons of torque, of primary stability. And then at the same time, we did a connective tissue graft. Just to show you that, of course, we all face the same issues.
Yes, no, of course. And I think that, as I said before, I think inserting the implant in that bone is really tricky for two reasons. One, because of course you are scared and you don't want to break the baby bone, and mainly because you're facing a very soft baby bone and a very hard native bone. So you must be extremely precise and very gentle. There was also a question.
Yes, Isabella, it's also very important because today there is a trend in implant dentistry to use very aggressive implants.
Oh yeah.
It's from Straumann or the Nobel Active from Nobel, and I think they are not very good implants to tell you the truth, because it's impossible to remove it, and sometimes you have to remove the implant. But in this particular bone, you should not use this type of implant. They are too aggressive.
No. I paid it on my own skin. I remember when I was positioning a very aggressive implant with aggressive threads, thinking, again, as a mistake, that being baby bone, I wanted to grasp and to have more aggressiveness in that sense for the primary stability, which was useless anyway, because you do never load an implant in vertically regenerated bone. And when I went back to actually load the implant for the provisional restoration, the whole implant came out in my hands. So it's obvious that, you know, this taught me a lot. So really also the preparation, I really changed completely the preparation. I always prepare to the diameter of the implant, and I gently position the implant, and I don't care if it has 20 Newton torque centimeters of stability. In fact, it's good, because then I will leave it, the coagulum will start its process of osseointegration, and 4 months down the line you're ready to load the implant. So that's not a problem. There is also a question about whether we always do the connective tissue when we are using the PTFE membrane. The answer is, in the aesthetic areas, basically yes, always, because the PTFE membranes tend to thin the tissues. We still do not know why, and this is one of the research questions that I am actually investigating. David doesn't know this, but I'm telling him now, live. Yeah. Don't worry, I'll tell you. But it's interesting to understand why this happens, this phenomenon happens, because we see it all the time. Isn't it true, David? Yes, all the time. We use these membranes. Obviously, one of the reasons is that because you release the tissue, so you're actually pulling the mucogingival line and dislocating it, but that's not the only reason. You really have a thinning. So normally we do this. Now, shall I carry on with the Paul?
Yes, you can share your screen.
Yeah. And then you can, okay. here we go. So this is Paul, and you can see, you know, a nice volume of I like the vascularization because it's very nice to see all those angiogenesis process that has performed. These are two implants. These are two Tomin implants that I have positioned, obviously with a different diameter, being a central incisor and a lateral incisor. And then this is the final case. This was the pros was done by Bob Toe, a colleague in the UK who was the referral dentist. And funnily enough, if you look at the soft tissues around the implants, they are more coronal compared to the native teeth. So you know, if this was a high smile line, I wouldn't be that happy. So even this requires a lot of thought, you know, where you put the color of your implants based on the final result. I like very much the occlusal view because you can see the beautiful round volume of bone. And I like obviously the tissue surrounding the implant crowns is very natural, very thick and very appropriate. And this is Paul and his smile. So it's he obviously doesn't show this, but I think, you know, the overall result with definitive crowns was very natural and very stable over time. What do you think, David, about the fact that the tissues were more coronal where the implants are, paradoxically? Maybe we've built too much compared to his natural teeth.
Also, down the road, depending on the patient aesthetic expectation, you can still do a lot with the provisional restoration and push the tissue. I mean, but at the end of the day, the outcome is nice. The patient is not showing, so sometimes you can stop. You can stop because the outcome is already good.
Yeah. Okay. So if you want, I can share with you the surgery of a very complex case, which is Nabil. Orestes knows this patient very well. Orestes and I worked in the same practice, by the way. That's why we share the cases. He's my prosthodontist and very talented and excellent prosthodontist. And Nabil is a very complicated case because we're dealing with a young gentleman. He's in his early 30s with a severe vertical defect in lower anterior mandible, which is one of the most difficult cases. So let me share with you the video, which finally doesn't have any music. This is quite a long video that shows you very well. Look at the defect. Look at the extent of the lower anterior defect. There is a crested incision. I apologize, the video is not very high quality. Sometimes it goes out of focus. You can see how gentle the lifting of the papilla is, all the flap management, but you can notice already, you know, the severity of the defect and the difficulty of the area. If you look at the base of the tongue, this is approximately a 10 to 12 millimeter vertical defect. I always clean the bone crest from any remnants of tissue, periosteum that was left, which you shouldn't leave. Now we're dealing with, what is it, 12, 13 millimeters of vertical defect, yeah. Okay, wait a second, I want to stop it because I want to do, sorry, this is informal. I can do, yeah, so this is like, okay, this is the measurement, and even the mesial distal dimension is significant because we have a 20 millimeter from mesial.
We can't hear you correctly, Isa. Get out of the Alps.
Can you hear me now?
Yes.
Wait a sec. Okay, I'm back. Okay, if you notice, I am using the micro scraper that I was mentioning before, which is much more efficient and much easier. Now this that you see is not the membrane, but it is the paper of the actual container of the membrane, which I use as a stent to make sure that my membrane is cut correctly. And this, I think, is very valid as a tip, because if you start using your sterile PTFE membrane and trying it in and out of the mouth with the saliva, it's not the best idea because you could easily get the membrane infected. The membrane should get into the mouth once. And to be able to do this, You can either plan your case on a 3D model, or you can use simply the paper of sterile paper of the actual container and shape it accordingly. And I think this is something, you see, I'm trying it, I'm making sure in here, I'm using the membrane which has been cut in the right position, okay?
Can you give us some detail about, because it's one of the questions, how you release the flap and when? At the end of the surgery, before placing the
flap is always released at the end of the surgery. There are two main reasons for this, which is very important. One is that when you release the flap, bleeding occurs because you're cutting the periosteum, which is highly vascularized, and you do not want to have a surgery which has extensive bleeding, because it complicates your life without reason. And the most important reason is the second one, because you are actually, because you're cutting the periosteum, you're releasing part of the vascularization of the flap. You want to be as quick as possible then to close the flap. You don't want to leave a flap which is obviously more fragile for a long term. Can you hear me?
Yes.
Yeah. Okay. So in terms of how do I release it, with a brand new 15C blade, I release and I really just simply open the periosteum layer in a very, it's just the periosteum. We never go and we never release the muscular tension. We only detach the muscular attachments, but we never cut them. I think the video from Paul showed it, but oops, I'm not sure what I've done. Let me go through this and I will show you the releasing here. So we've come here. This, okay, so we are making the stent, and here this is the membrane. So I put it and it's already ready to be there. Can you see the screw that is attached to the handpiece? And even though it's a very hard position, I managed to go lingual and secure it in with two positions, mesial and distal. Once it is completely attached, I can use the membrane as a wall to start building up everything that should be regenerated. You can see here the scaffolding, which is 50% autogenous that you've seen. There, this, I will stop it for a second. This instead is the typical tack, which we use with the mallet. So the screw was in the lingual, the tack was in the buccal. There is no law, nothing, that you can use whatever you want as long as the membrane is secured.
Yeah,
I find
one law, it's avoiding to lose the screw within in the lingual area.
Yes, definitely. That's extremely important. Well, I give it kind of for granted, but yes, I agree with you, David. And I think you'd said a very important thing, because we may give it for granted, but it's very difficult. I must admit, this is a surgery that requires, as we all know, a long learning curve, especially in these cases, which is very intense, but it requires also a very good team with your nurses. You can do this only if you have two nurses next to you, a sterile assistant and a sterile instrument assistant, because you really need help. The assistant has to hand you the screw perfectly inserted in the screw holder, whether it's the handpiece or whether it's the straight screw holder, making sure this doesn't fall. So I'll show you how I fix the membrane in the buccal portion. There I go with the mallet, and also very careful. One other thing is being very careful not to put the screws or the tacks where the roots of the teeth are. This is extremely important. Remember that if we have the teeth and we also have the roots of the bone, and sometimes I've seen during the courses or during the explanations of the postgraduate students, they forget that there are roots there, and the last thing you want to do is to insert a screw inside the root of the adjacent tooth. One other tip is not to panic too much. If once the membrane is fully, completely attached to the actual site, if it hits the teeth. Why? Because with a brand new 15C, you're able to cut it around the tooth to make sure it doesn't touch the teeth. There, you see? So it's nice because you can kind of recontour it in the most appropriate way without touching the teeth. And this is the actual, there, this is the release of the periosteum. I mean, you can't see it very well, but it gives you the idea of really how delicate this whole process is. And then it's also a matter of detail, the bundles and the fiber. The suturing is always the same. It starts with a, it ends up with interrupted sutures, always, especially for the interrupted sutures.
So it was not clear. It's mattress suture using EPTFE membrane, huh?
Yes, correct. It's always mattress suture, horizontal, to be able to give the 2 layers of closure. The more the superficial and the deeper one. This is the end. This is the end with the interrupted sutures on top. And you already know when you do it. Yeah.
No, just one question and comment on the management of the lingual flap as well.
Yes, so the lingual flap does not require any, wait, let me get out of this. The lingual flap does not require any specific releasing incision, because it would be too dangerous to perforate the flap. So what we do, what we do is we stretch it with the 2 tissue pliers. We tend to literally stretch it, and I turn around the 15C blade and I really scratch it, almost like peeling the layer off. Okay, so it's never cutting the periosteal in that sense. One other tip is that you can potentially insert and create basically a larger flap. So let's say that you're like Nabil, you're treating from canine to lateral incisor. In the lingual, you can extend intrasulcularly to 2 teeth away, 3 teeth away, to be able to have more flap extension. Does that make sense?
Yes. Okay. I just replied to Ricardo. The screw, it's called Profix.
Profix screw.
And the tags, you have several company. We like the Italian group. It's MC Bio, huh? Right?
MC Bio, and it's the MC Bio are Italian and the Profix screw are American.
And I like the MC Bio because they are strong and they're really efficient. We have also a question from Jean-Marc. I have no experience with Ocel at all.
No.
But it might be a good option. Of course, it might be a good option just to check. But I must say that I'm never worried with the implant primary stability in site where there is a GBR. Really, if there is a vertical mobility, then it's an issue. But sometimes I place the implant and then I screw the cover screw. It turns, and then I wait a little bit more. But today with the new particularly the new implant surface, it's really not an issue anymore.
Orestes is asking, when you do the connective tissue on the membrane exposure stage, do you place the connective tissue subperiosteally? The answer is yes. The connective tissue should always be in a partial thickness envelope. So I think this is a very easy message. Every time you use a connective tissue, it must always, at least in part, be inside a partial thickness pouch. Let's put it that way, right?
Yes.
And I see a question from Niline asking about the complication of the bleeding coming from the sublingual artery. Now, it is very important. You say, how do you manage this complication when you use the blade to release the lingual flap? I do not use the blade to release the lingual flap. So exactly for this reason. So it's very important to always stay within the anatomical regions of the myoloid muscle insertion and never go beyond this to be able to be able
to go a little bit to give you some more detail, let's say that the only area when you can eventually use the blade, it's the premolar area. It's the only area where you can really slightly use the blade, not in the anterior area, not in the molar area, where you just have to pull the tissue, and it's sufficient.
Yeah, but to be honest with you, I mean, we've done loads of lower jaw cases, which and I find it much easier to release the lingual portion and the buccal in the lower arch compared to the upper arch, because we know the upper arch, for example, the palate you cannot touch. The palate is completely stiff. So in fact, in terms of releasing, then I think the lower arch, which is more, it's harder because you see less, but it is easier from a soft tissue, from a flap management. Not, David? I mean, I don't know, maybe.
The only thing is that the people, they used to use the blade, and then when you use the blade, then it's, if you avoid using the blade or very, very slightly, then there is no issue anymore. And yes, Nilen, I don't know if it's the right pronunciation, you can use a blade donati if you like, instead of the mattress suture. But in most of the publication, most of the people, they use the mattress suture because you have this reverse effect on the wound, and that's why we really love the mattress suture together with the sling suture, or together with the interrupted classical suture.
Yes. No, honestly, David, I think that that this suturing part is extremely serious, like very. It's one of the key aspects of the surgery. So I would really recommend you guys that, to be honest with you, once you have released the tissues and you're ready to suture, you already know intimately in your heart whether this case will open or not. Let's be very honest, because once you have released them, come on, once you have released it well, you know that that is not going to open if you suture it with a horizontal mattress suture and the interrupted. If you have any doubt, it means there is some tension. And those are the cases which open. And most of the times it's because you're exhausted, you're tired, you said, okay, done. I've released everything. I'm scared. I don't want to go next to the nerves. I don't want to go and risk any artery perforation or whatever. And I'm not going to do anything more. And this is, I think, the biggest mistake. If you want, this is an aperitivo with a glass of wine, and this is not a lecture, like a scientific lecture. This is really like a friendly, chat, as if David and I were alone. And I would tell David, this message, like, honestly, be ready when you suture that your flaps are super released, really without tension. And I think that makes a massive difference. I put too much heart in my surgeries, David.
I was just looking at the Enrique Merino. Do you make holes in the buccal bone plate to make bleeding?
Yes, I do when the cortical is very thick and I see that the case is not bleeding spontaneously. Most of the cases recently, I don't know, probably because they were really extreme cases, the buccal bone was very thin. And I'm not sure if David would agree. When you open and you see that the bone is bleeding spontaneously, there's no need whatsoever to do perforations. And if you actually do perforations, stay away from the areas where you're going to fix with the tacks or the screws the membrane, because a lot of times you're perforating and then, oops, you've got a Swiss cheese effect and you don't know where to put the screws in.
And when you, Enrique, when you use the handpiece, and particularly the Profix, which are self-tapping system, then it's you don't have to put a hole in the membrane, and you use the tissue plier, and it will not twist the membrane.
No, it doesn't twist. I mean, the PTFE doesn't twist. Obviously, we're not talking about the collagen, because those would twist. So I never use the screws around with a collagen membrane. Only use the tacks if you want to fix the collagen membrane. But if we're talking about the PTFE membrane, it doesn't turn around. It doesn't twist.
Isabella, I don't know. It's weird because we have started 1 hour and 30 minutes ago, and
oh my God. Oops.
And there is more and more participants. So first of all, stop with your family, Isabella. It's enough now. It's all the family of Isabella is coming for the aperitivo. It's like,
well, considering the family is very young, I don't think they are family, but still, yeah. No, it's really nice to have you guys, and yes, it's fantastic to have you all for an hour and a half. Wow, that's a lot. Maybe they're fed up of us. Maybe we should just drink and chat of something else.
about the next vacation. Oh no, there will not. There won't be any next vacation.
We need to work so hard now to catch up. I know, guys. I mean, look where we're doing it from a home, from a room. I must say, seeing these surgeries make me really want to go back as soon as possible. But guys, if you have any other questions, you can also contact us through our website. Maybe David, we want to. Yeah, you have it behind you, but it can't be seen. But wait, let me show you the. I'll show you there. So if you want to write to us, maybe you can't see it very well. There you can see it. It's id2courses.com. Well, these are the courses for 2021, but that doesn't matter. I just wanted to make sure that if you have any cases you want to submit, I mean, we are a group of friends. We are really increasing our network. We have a great alumni group, which is fantastic, of our ex-alumni. And we're also thinking of doing a lot of more stuff with ex-alumni. You're more than welcome to join. Send us an email. Remember, guys, that if you want the certificate, each one of you should send an email to Kala asking with your name and last name, and it will be delivered to you very, very fastly. So
and I really hope I will be able to come to London in November.
Yes, I really, really hope, and fingers crossed that life goes back to normal by that time. I doubt it, to be honest with you, but maybe it's going to happen. In any event, we have the 2021 dates, so it should be okay. And
You disappeared.
I'm here.
The connection in Italy is not that good.
No, I must say the connection where I am, that was my biggest fear for today, and I think it's it really worked decently enough.
Yes, it was good. So thank you to everybody for being with us tonight. Don't hesitate to send the email or question if needed, and
just keep in touch, guys. Keep in touch. Send us cases, questions, and we'll do this over and over again. We'll do probably one a month or something, like little pills of chit-chatting. Okay?
Could be nice.
Yeah.
So,
have a nice evening, guys, and enjoy the rest.
keep in touch.
Bye, guys.
Ciao, ciao.
Enjoy. Bye.
See you all around.